I'm excited to be able to introduce our keynote speaker for this year's annual symposium, Ann O'Brien. I'm very excited, accepted our offer to travel here from the left coast to come to the East Coast and hopefully enjoy some of our East Coast spring weather this year. So I think it was just last week it was still snowing, right? So so the sun has come out and we should have some nice weather for you. So Ann O'Brien is an accomplished thought leader with over 25 years experience in nursing informatics and clinical transformation. Her contributions have focused on system-level strategic optimization of the EHR data and technology to improve patient safety and quality outcomes, most recently at Kaiser Permanente in Oakland, California. Ann has a BSN, an MSN in nursing, and a postmaster's in nursing informatics. This past year, Ann was one of 4 recipients of the FHIMSS 2018 Most Influential Women in Health IT Award. Very impressive. Ann is a tireless champion of nurses, mentoring many emerging clinical informaticists. Among many of her contributions, Ann has partnered with the VA on the development of a nursing information model, process, and participated in the Nursing Knowledge Big Data Science Collaborative with a strong commitment for transforming nursing documentation. She is designated by Modern Healthcare as a top 25 clinical informaticist and has served on the National Quality Forum's Patient Safety Steering Committee. Ann is a Robert Wood Johnson Nurse Fellow and a Fellow in FHIMSS. Her passion is improving clinical processes to move from data to information to knowledge in order for clinicians to provide highly reliable, evidence-based, personalized care. Please join me in welcoming Ann O'Brien to the stage.
Good morning.
Good morning.
Well, I'm really honored to be here and so glad that I was able to bring you the warm weather because I hear it's going to be sunny and 70 tomorrow. So I can take full credit for that coming from the San Francisco Bay Area. I'd like to thank Denise and Mary and the entire NENIC board. And we were talking last night at dinner. All of you should feel very fortunate to be part of the New England area and participate and get the quality of this board and this organization, because that's not the case nationwide. So congratulations, and it's really an honor to be here. What I'd like to do today is sort of give you an overview, since your theme is about trends. I am going to talk about some trends. I'm also going to talk about some challenges, some work that we still have to do. I'm really thrilled to see so many young people in the audience, because there is some of us that are going to be leaving the profession at some point, and it's really, really nice to see the next generation here. Sometimes you go to nursing conferences and it's a little bit different. So congratulations to all of you who have gotten the memo that we really need nursing informaticists for the next 20 years. So I'm going to talk about some of those challenges and then some opportunities specifically for nursing informatics. How many of you are nurses? Is everybody a nurse? Anyone not a nurse? Programmer, Epic, okay, technologist, Epic builder, analyst, data science. Anything else? Pharmacist, thank you. So that's why we call it clinical informatics, because we are all one team. And I'm going to talk a little bit about the value proposition of informatics, all of clinical informatics. And I'm so glad we have a pharmacist in the room, because I'm going to end with sort of a little scenario of an example that I think puts all the pieces together. So I want to start with where we are with healthcare, and I'm so pleased that now when we talk about healthcare, we lead with talking about health. And so I'm going to start with a little bit on health and healthcare and the implications for all of us in healthcare. Talk a little bit about the quadruple aim and where we are and the need for more efficiency for our clinicians, and spend a little bit of time on highly reliable systems, because I think that this is an area that nursing informatics and clinical informatics can really be an enabler and a leader in that space. And end with a little bit on teaming and sort of the how to get this work done. Okay, so in looking at health today, I love this slide because it really represents that it's no longer just about your family history, and you can see that medical care is only about 10% of what we're dealing with. So if you think of any person and any consumer, most of it is, and most of our health is related to those personal behaviors. So I want to stress this, and I was really pleased to see, I was reading the paper yesterday, and it had this big ad that the first key to health is food, and it was a full-page ad on food. But in reality, this is what's going to determine the health of the next 30 years, is our personal behaviors. So getting 8 hours sleep and eating well, and make sure that you're getting your exercise. Social factors and environmental factors are key, up to 20%. And then about 30% in terms of your genetics and genomics. But the medical care itself is only 10%. So why do I show this slide? Because it's really important as we look to the future that we're really moving more towards population health. And that the care itself and the patients in the hospital are not representing our ecosystem of health today. We're going to be moving more and more into new roles such as community health educators and nurses, and nursing informatics and clinical informatics is going to be key in this journey. So in terms of the health of the United States, as many of you know, we're really behind some of our other countries, especially over in Europe. What I like about this slide is, one, it's old, 2000, but it represents the number of people with chronic diseases where we're moving to. So I went on and updated it, and this is from the RAND Corporation, that 60% of adults now live with at least one chronic illness. So isn't that staggering that by age 60, you have 60% of adults that live with at least one chronic illness, and 4.2 have more than one. So we have a lot of work to do in the area of health and wellness to turn this around. But if you look at the graph, what was predicted by 2030 was 49%, and now we're already at 60. So what we thought was going to be the case in 2000 is now so much more. So when you think of the epidemic of obesity and diabetes, it's significantly more than what we thought it was even 17 years ago. This is dramatic. And the same with Alzheimer's disease. So Alzheimer's disease itself has increased 50% in the last 15 years. 50%. Look at the scope. Look at the slant of that line. This is important. And again, we're going to see just a more and more focus on your social determinants of health. Again, sleep, food, plant-based diet. We have to, as Americans, turn this around. And nursing is going to be key. So I'm going to switch now to talk about as all of you have heard about the triple aim, everyone in this room should know that the triple aim from the Institute for Healthcare Improvement involved patient experience, population health, and reducing cost. With, over the last 10 years, as you know, most of it has been on decreasing cost. But now we have this epidemic of burnout and burden that is coming upon our clinicians because of the electronic health record and all the new devices. We're adding to the work of the clinician. So because of this workload, physicians are working all day and then have to go home and adding 3 hours of answering emails, extending their day. Nurses, we keep adding more and more clinical devices, more devices, biomedical devices, more things to document. And so this is leading to more challenges as it relates to the clinicians themselves. So the fourth aim is really improving the work life, satisfaction, and efficiency of all clinicians. So we've really sort of graduated from the triple aim to the quadruple aim. And I think that's a really important construct for all of us. That as we're working on our projects and you're checking in with the nurses, it's really important to say, how was your day today? You know, did you get a break? Are you able to support your manager? Are you making sure that the right information is getting to the right person at the right time? So I'm going to switch now to sort of this sense of electronic health records and what they have done from a positive and a not so positive side. So back in 2015, AMIA, that Denise is involved in, although there was only one nurse on this study, but AMIA did a task force called the 2020 Task Force. And these were the key recommendations. But basically, simplify and speed documentation and decrease this sense of a documentation burden. So although there's a lot going on right now related to documentation burden, it's not new, as you can see. 3 years ago, the AMIA group pointed this out, that we need to simplify regulation and increase transparency. And we'll be talking a little bit more today, and Dan's going to be talking about data transparency and data visualization. But we have a lot of work to do to move towards having tools that actually move us to patient-centered care. So this was from 2015, and again, sort of on the AMIA side. Now, this is brand new, fast forward to a month ago, March of 2018. And the reason I'm citing this is I really like Kevin Flickenshire. He's a physician. And so this came from Health Affairs. And the reason I like it is that there's a small group of clinicians that are proposing that there's going to be another whole specialty in addition to informatics called medical virtualists. And I'm not promoting this, but I wanted you to be aware of it. And I like some of the concepts that are brought out here. So they're saying that we right now are dealing with disease management with very isolated data points and periodic interactions, because that's how the care is today. But we have the demands of digitally empowered patients. 95% of Americans have a smartphone. Even the homeless people in San Francisco, they're homeless, but they have a phone. So we're moving now toward defining actionable intelligence from continuous data streams. And that's what I think is an important concept for all of us to think about. We're moving away from this intermittent, well, this was their blood pressure an hour ago, or this was their labs an hour ago. And we're really moving into more of a continuous stream of data and a population health and population driven and very individualized, relevant, and personal. So that's what I really like about this. And do I think, and the article says, well, no one thought we would need hospitalists either. So they're saying that medical virtualist is the next thing for physicians. We'll see. So getting back to the burden, I'm going to quickly go through these, but at least you have the slides. What I want you to know is that Department of Health and Human Services, Office of the National Coordinator, and CMS has an initiative right now to look at this area called reducing clinician burden. So this is brand new this year, 2018, and you'll have all of the links that you can go and read. Also, they're saying that their top priority at CMS is putting patients first. So it shouldn't be that we're just focused on documentation or, again, this intermittent disease-focused care, but we really need to be looking at the patient as a whole person, and they're saying reduce the burden, increase efficiencies, and improve the experience of the clinician. We'll see what this comes out to. It's easy to say that. I think it's a little harder to actually do when you have these very complex systems and we keep adding more and more devices. But at least it's now a designated priority. Also, what used to be called the Institute of Medicine is now called NAM, the National Academy of Medicine. So we're getting used to a new acronym. But they also are looking at care-centered documentation to alleviate burnout. So you're seeing a trend here that AMIA, ONC, the Office of the National Coordinator, CMS, and now the National Academy of Medicine. So everyone's gotten the word that clinicians are burdened, and we have to look at new solutions to make the electronic health record and our processes better. And this is where nursing informatics come in, because we understand how to look at a workflow and make it work for that clinician and remove some of the clutter and some of the burden. And there's also national initiatives to look at that documentation as well. So with that as an overview, there's many recommendations that are coming out from NAM, but primarily we should only be entering what is appropriate to be entering. And they're finally saying this is a computer system. Maybe we shouldn't have to re-enter the same information if it's already in there somewhere. So better data views and pulling that data together in a way that makes sense. So I'm going to now transition into nursing, and I would be remiss if I didn't mention the Nursing Knowledge Big Data Science Group. And Denise mentioned this as part of my introduction. I had the pleasure of being involved in the first group. The conference is coming up June 13th. It's held at the University of Minnesota. And Bonnie Westra and Connie Delaney are sort of the conveners. And I'm not going to say the leaders intentionally, because it really is a national effort. There's vendors there, so Epic will be there, Cerner will be there. There's scientists, many nurses from academia, and we need more, quite frankly, from practice. So I hope some of you are planning to go. I know it's right around the corner in June. So I was involved in the Transforming Nursing Documentation Work Group, and I chaired that for 2 years. It's now chaired by a colleague of mine at Kaiser Permanente. But the reason we have this little faucet here is when we started this work in 2015, we characterized the electronic health record as a DRIP, data rich, information poor. And so you have all this data, but how do we actually move towards getting actionable information, the right information at the right time for the right person? So this was an article that you can Google. It was in Nursing Administration Quarterly. It'll be available for you. It was called The Hype and the Hope for Improving Nursing Satisfaction and Quality Outcomes. So again, it's not just about having it be easy to do the right thing, but we want to be able to have the nurse be able to have within his or her workflow the evidence-based practice right there as part of the workflow. So I see that as a big role. I'm not going to go through all of the recommendations from this work group, but you'll have it with the slides. But I would encourage you to go to the website, and if you just put in nursing knowledge, big data science, the conference will come up. All of the proceedings from the first 5 years are all on there. That is a data mine right there. I mean, and they don't just have one work group. They have the social determinants. They have the coding nursing information model, and then coding that, the Sue Matney work on coding all of our nursing concepts to SNOMED and LOINC. There's the social determinants of health. There's maybe too many work groups, but there's a lot of different work groups that you can get involved in. But if you go to their site, it is a powerhouse of information because every single PowerPoint is there from every single session. Why is this important? In my opinion, and I did my postmaster's way back in the late 90s, and at that time, Sue Bakken was famed with really looking at nursing data and making sure that we have a way to measure nursing data and that it's coded and that it's clear and that we have one way to do it. So for those of us who have been around way too long, we went through about 25 years of arguing about nursing models and how there was many. Nick, knock, paddywhack. I mean, there's just so many that it was challenging. So it wasn't. It challenged us to look at, well, how do we come together? This is important. Nursing data is important for us to have one way of looking at it, and that's what I credit this group for. Because we don't have all of the answers, but they're putting it together in a way that they've determined there is a way to do a nursing information model around a content. So we've done pressure ulcers, and they just did all of falls, and that there's actually an information data process to do that with experts, with evidence, figuring out what those most important elements are, getting them coded to SNOMED and LOINC so that we can have nursing data be shareable and comparable, whether it's with the hospital down the street or with Cleveland Clinic or with Kaiser Permanente out in California. So this group is helping to gel that and coming up with the standards that we haven't had in the 80s, 90s, and 2000s. So great group, and I hope you'll check that out. So now I'm going to look at, well, where are we today? And I think there's a lot of challenges. And I'm really honored to be in nursing informatics because this is the hard work that we do. The environment is not coordinated, whether we're talking about data or clinical communication. If you're a nurse in the clinic or in the hospital, it's noisy. And we have a lot of alarm fatigue. 5 people could do their dissertation and their DNP on decreasing the noise and making alarms and events, alerts more actionable. Nurses still carry multiple devices. I mean, unless everyone has figured it out and had the money to fund everyone with a smartphone. I know that's not the case on the West Coast. Nurses are carrying multiple devices, but there's still care gaps and interruptions and lack of knowledge are pervasive. So this is our work. I mean, nurses really are, I believe, the information integrators. We know how to do the workflow. We know what's in the electronic health record. We know how to get to best practice because many of us have that background of education, support, your clinical specialty. And so there's there's an acknowledgement that our current state is there's a huge memory load on the nurse. And so the environment itself does not support efficiency, and there's a lack of actionable information. And I think we're getting there, no matter what electronic health record system your organization is on, or if you're on the journey to do that implementation. They're getting better. Epic is a lot better. Cerner is a lot better. The other vendors, the integrators, Connexall and all of those systems, they're better. But there still is not easy interoperability. Does this resonate with folks? Do some of these seem like this is the current state? Okay. So we're acknowledging that we have really, really good work security for years to come. Whatever piece you like, there's a specialty for that. One of the things that I think is absolutely critical, and I can't stress this enough within the next 32 minutes, is that EHRs do not support interprofessional collaboration. So one of my take-home messages, and I'm going to talk about it in my example later, is that as we create projects, make sure that you have a pharmacist on the project, several physicians on the project, from someone from your EHR or Epic or a builder, someone that knows what's coming in Epic 18 and has all that in their head. But having interprofessional collaboration is what I think is going to turn this around. So as I said, nurses are the error detector system. Why is this important? This is important because medical errors right now are the third leading cause of death in the United States. Did you guys realize that? The third leading cause of death. So even though the Institute of Medicine came out with the IOM report in 1999, that was 19 years ago. We are not getting better at getting better. The other article, in addition to the third largest cause of death, is the $17 billion problem of measurable medical errors. The reason I have both of these on here is as we look at measuring the value of nursing informatics and clinical informatics, you have a place to go. You can improve care. You can improve safety. And there's a space for that. No one has completely figured this out. We still have a problem. So just looking at sort of, as I said, 1999 was to err is human. They said there was about 98,000 deaths. Now, 19 years later, they're saying that that was really an underestimation. So that's why this article in the third largest cause of death makes the point that medical errors aren't part of an official why the person died. So it's really hard. It's not included in the death certificate or in any of the rankings of cause of death. So it really is probably much higher than the Institute of Medicine. Nursing can help. Nursing is there at the point of care, whether you're a staff nurse, nurse manager, chief nurse executive, or the informaticist who is helping all around that care. So I'm going to switch now to sort of the trend related to data and informatics. I'm not going to spend a lot of time on this because Dan follows me and he's more of the expert, and that's the focus of his talk. What I'll say is that we need to move from retrospective to prospective. So we have the tools. You shouldn't find it acceptable for your nurse manager or your nurse director or your chief nurse executive to be looking at data that's a week old. It's just no longer acceptable. I mean, we have the ability. How many of you have something like Pew's that's a predictive for, not that many? Oh, some do. Okay, raise your hand. So we also have the tools to predict early detection of deterioration and early detection of sepsis. So all of your med-surg nurses and all of your nursing assistants, when they take a temperature or they take a respiratory rate, they need to know that that's not only important and valuable, but it's part of a predictive model that's telling us which kids are not doing well. And I think this is an area for nursing informatics to work on, because I think nurses don't always value that data. And we know that because if you look at if they're putting it in real time, they typically aren't. There's still nurses that are part of that other generation that started when we had the paper flow sheets that don't always put data in real time. So this is also an important takeaway. You can go on in any system and look at the time that they put it in for and then the filed time. And that shouldn't be 40 minutes later or 2 hours later when they got around to putting it in. The only way that predictive models are going to be effective is if data is in real time. So we're moving into this new space of intelligence and machine learning. You're going to be hearing more and more and more about that. This is actually a slide from Epic Systems that I'll give them credit for. They themselves, as a vendor, are moving into this space and creating many predictive models. So in their 2018 version, you can purchase or you can have some of their predictive models for sepsis and other things. But where they're going in the future is many more opportunities for augmented intelligence related to patient flow, engaging patients, genetics, genomics, and do you notice? Happy physicians. Happy physicians. Okay. And if you happen to ever go to an Epic UGM meeting, it's fine to go up to Emily Berry or to one of their leaders and say, it would be nice if Judy Faulkner just once used the word clinician and not physician. And then also, this is just another picture from Epic that was from one of their recent slides. And again, it shows the future that I think is important, that just like at the beginning of the talk, we talked about that there's many, many areas of data. We have our social determinants of data, where they came from, and now everything's going to be put into these models, everything. So for example, at Kaiser Permanente right now, we can look at the pollution level in Richmond, California, and actually send a text to a mom of a child with asthma and let her know that the child might need more asthma medication today because of the pollution level. So that's here today. But suffice it to say that outside data, EHR data, current data, and then all these machine learning libraries and predictive models running in the background, that is our future. And the future is here. This happens to be an Epic slide. I'm not promoting Epic in any way, although they are taking over the world. But Epic, Cerner, and the other ones that are out there. And I say that in jest, but not really, because there used to be 25 electronic health records, and now there's 3 or 4. So we do, as a nursing profession, need to stand up and have our place as leaders. So I'm going to shift now to the next theme and talk about, so we have all of this data, we have a burden, We have electronic health records. We have a shift related to moving to smart devices. We have units that are uncoordinated. And so how do we make this work? How do we actually come up with writing a strategy in collaboration with your COO, with your CNE, with your CFO, and say, how do we actually work together to improve outcomes? In my opinion, it's really important to study the work of highly reliable organizations. This is the processes that are going to get us there. So we need the data, we need the predictive models, we need documentation in real time, we need the evidence, but as a system, we have to work together. So this is some work from Tim Voges, and I've heard him speak several times. He's from Vanderbilt. But to understand that a highly reliable organizations, such as a large healthcare system, are complex, dynamic, interdependent, and time pressured. So that's the world we live in. It's constant. But if you want to look at what actually produces high reliability to get to everyone being safe in the operating room, doing a timeout every time, making sure you're 100% preventing falls and pressure ulcers. You need to have an entire culture around safety. And I like his definition that it says that safety culture is a product of shared values, attitudes, and behaviors, and that it's visible. You know when people are working together. You can walk on a unit and immediately know where we are on this unit in terms of people working together and what that culture feels like. So the principles of high reliability are sort of this preoccupation with failure, but also a resilience that if you have a medical error, say it's been 92 days since we had a fall on this unit, and you have to take down the piece of paper that says 92 and put the 0 back up. Instead of being overwhelmed by that fall, you have to have a resilience about it. So although you have a preoccupation with failure, there's a reluctance to simplify the interpretations of how that happened. And one of the most important, and I have it in bold here, priorities related to high reliability is deference to expertise. So for all the leaders in the room, if you're an executive, nurse exec, CNIO, this is really important, and I work really closely with leaders and upper level executives that if you're doing a project, make sure you have someone who's an expert in that workflow. And this is what I love about nursing informatics, because you'll walk on the unit and talk to the nurse that's actually doing the process and then do your little Visio of the workflow, et cetera. This is important. And I think where organizations tend to fall down when they write a strategy is that they miss this step on deference to expertise, which is why it's so difficult to actually achieve highly reliability. So the next frontier, the new buzzword after HRO, highly reliable organizations, is now systemness. So I'd be remiss if I didn't say systemness 3 times. So what is this? This is where you're taking the very complex health system and you're making it a single integrated organization. So you're sort of putting the operating model and the system all together, and that there's alignment of the leadership, the physicians, the IT infrastructure, and the care delivery model. Meaning people actually have to work together, but also that the organization itself is integrated. So sort of a move to more of a value-based care model that the physicians and the organization and the insurance company all work together. So this is the next frontier, and the way that we're going to really be able to move to repeatable and reliable and consistent processes that could elevate our patient experiences and get us to the safety benefits. So I'm going to just give you some examples of some articles that I think are important for you. You have the references. I'm not going to go through every point on here, but I want to point out that here's an example of an article on a CNE-CNIO partnership from 2014. And then also Patty Sangstack wrote a great article on the CNIO as a strategic partner. Both of these, in my opinion, are seminal articles and are important for you to go back and read, because we need to be able to have the CNIO seen as a strategic partner who is linked with the CMIO, the chief nurse executive, and your chief financial officer. Because again, cost matters. And it's all of you who are going to be able to create that systemness and those highly reliable workflows that lead to quality and efficiency. So we were talking last night about what is that value. And so I think that there's many, many different areas. There's many, many different projects. And I think what's exciting about clinical informatics is that we have a very diverse value set and skill set. So if you look at strategy, defining systems, designing a new system that comes in, oh, well, we want to do a virtual ICU, or we want to move to smartphones, or we want to do biomedical device integration of our 17,000 large volume pumps, or we want to, create a new model. This is the kind of opportunities that nursing informatics can do to get us to interprofessional teams and evidence-based practice. So these are here for your detail. But it's a wide range. It's everything from it's very much like the nursing process, doing the assessment, doing the design, implementation, and I can't stress enough the metrics evaluation. How many of you have some training in PI, performance improvement? So for those of you that don't, I would encourage that. Maybe think about taking a little course or going up to the Institute for Healthcare Improvement. Oh, it's here. It's in Boston, right? Yeah, go to IHI, get trained. And again, I'm not proposing any model, but there's a science to understanding the process metrics and the outcome metrics, and you're going to need that to demonstrate the value of your work, because you have to translate that into, I saved this many minutes, I saved this much cost, I saved, we had 20 pressure ulcers last year, we can make it to 0 with this evidence base, etc. So this is my example. I'm going to take just 2 minutes to talk about a project that took over 2 years. But what the point of the story is that we worked on a group that had clinical nurses from the front line, managers, nursing informaticians, pharmacy informatics, and several physicians. And we looked at how can we decrease or actually prevent delirium. And it's a big problem. It's a very big problem. So what did we do? That's not kind of sticking on there, but that's okay. So what we did was we really leveraged the electronic health record in ways that I think we should be assuming that the EHR is actually a computer. So again, rather than having to re-enter information, some of the things we did that actually I call smart, intuitive, in getting us to the right information is we created a risk score in the background. And I don't think you can see what's on there, but that's okay. Flashes. But anyway, so what we would do is the nurse would do the CAM, the confusion assessment method. We would know from the information that was already in the computer, the patient's age, if they were having surgery, if they had a history of delirium before. All of those things you already know, so you don't have to redo it. The nurse would do the CAM. Then we would be able to look at, is the patient actually at risk for delirium, or has the physician actually ordered a deliriogenic medication? And then they would go on, and it would be no risk or a little bit of risk, or red would be that they're at risk, they've had a history of delirium, or they have a deliriogenic medication. And then the other thing we did is we built a grouper in the background. So again, make the computer do the work rather than the pharmacist having to know or look up or be conscious of every delirious medication. There's a list. There's the Beers list. And so we built the grouper in the background. So you have the risk model in the background. You have the grouper in the background. All of this works together so that you can have an algorithm where you know who is at risk and what interventions they need at what risk. And if the physician actually orders a medication that's deliriogenic, then the pharmacist can, rather than, let's say you're at a big hospital and there's 1,000 beds, there's no way a small group of pharmacists can review every medication on every patient. But if you have a risk list and you know who is at highest risk, the pharmacist can review those medications. And if they're at risk, then the pharmacist would call the physician and say, your patient is at high risk for delirium, you ordered this benzo, do you want to change it? And 95% of the time, the physician changed the medication. So the point of the story is, I think the answer for us is interprofessional collaboration, leveraging the EHR as a computer, where you're actually building in models and risk models in the background and working together as a team. So the final thoughts, the new mandate is value. It's everything. It's cost, it's experience, it's getting to care across the continuum. And then the answer, interprofessional, knowledge-enabled, personalized care through, of course, informatics. And the how is we need to work as a team. I like this book, Amy Edmondson. She's right here at Harvard. If you haven't read this, it's a good thing to read on the plane or at night. The how is teaming. We have to start working together, creating these highly reliable organizations. We're in a fast-moving environment, and we need to know how to team.